With the T-cell lymphoma, the WHO and the new ICC puts 32 or 35 different categories in one box. So it depends on what you call as T-cell lymphoma, and broadly whether it's nodal lymphoma, which we commonly refer to as PTCL, and then the cutaneous T-cell lymphomas, the MF, and the extranodal, like the NK T cells and the hepatosplenic gamma delta T-cell lymphoma and the leukemic version. So it depends on where you go. There are different approaches, and all of them are not the same diseases. But the most common things first, the nodal T-cell lymphomas obviously are the ones that we as hematologists, oncologists focus a lot on, and we do see more statistically, and the number-wise, it's about 10,000 new cases at least in the United States. So we've been using CHOP-based therapies, and we've been trying to look for that target, for a biological approach to add to CHOP, because CHOP has only given us a certain response rate, and the Echelon 2 has moved the needle in a subset of lymphomas called ALCL, and clearly the responses have been very good, including progression-free survival and overall survival. Now there are these subsets of CD30 positive T-cell lymphomas which may also benefit potentially, and I say which may because PTCL, not otherwise specified, seems to have a clear-cut advantage with this strategy of going through the CD30 directed approach. So you, instead of using CHOP, you add brentuximab vedotin, take out the vincristine, and so this approach has helped. But there's also this 50 to 60% of the other lymphomas which don't express CD30. And we don't really have a target, and we've been using CHOP, adding etoposide based on a German retrospective study to potentially give the extra 10 to 20% response rates. But all said and done, I think we are looking for the right clinical studies. There are ongoing clinical studies. The Alliance study is probably the largest, which just started. Dr. Nehemiah Shah is running that study. We're also doing a study of looking at whether CD30 is actually important even if it's not expressed. And so we are doing this HPBV in the non-CD30 expressing T-cell lymphomas all the way up to 10%. And there are other ongoing studies that could potentially come up front. Relapse refractory setting is completely different. I think there's a whole slew of activity in the clinical trial space, but in reality, there are only 3 drugs that have been approved, 4, and one of them was withdrawn from T-cell lymphoma approval. So we're struggling with drug approval, so hopefully one of those clinical studies would translate. For cutaneous T-cell lymphoma, it's a multidisciplinary approach. A lot of the care is skin-directed. Subsequently, when it involves the entire skin, tumor stage, nodal stage, then we transition into biologics. We try to stay away from chemotherapy because most patients who get chemotherapy don't do well. There is a place for chemotherapy. We try to stick to biologics and radiation for skin-directed therapies. For the rare varieties, of course, we try to avoid anthracycline, the gamma delta, the extranodal NK T cell. We use approach of using methotrexate, ifosfamide, asparaginase-based regimen. There are different regimens. It's not a clear-cut winner for the late-stage extranodal NK T cell. And for the hepatosplenic T-cell lymphoma, another rare entity, but we see quite often, we try to use the EPOCH Hyper-CVAD approach. So as you can see, there's a variety of approaches depending on which T-cell lymphoma you pick.